But that's what we do. We come up with narrative documents. And there are problems with narrative documents. Our process, there are benefits. We do a first-rate review of the literature. We have a well-established process for this. It's very highly trusted. The family practice docs and the ER docs, I think, all rely on our guidance for helping them to treat folks. We own the standard of care. But what are the problems with these narratives? First of all, we review evidence-based medicine. Well, yeah, if we're trying to get from A to Z, evidence-based medicine goes like A to B, and then we got GH and MNO, and S looks really good. We've got good data on that, but there are huge gaps in creating these care pathways, right? They're open to interpretation. As Lario likes to point out, you need a lot of a priori knowledge to be able to read one of our practice bulletins. We say things like, well, if there are obstetrical issues, then you should do this. Now, Kate and I know what obstetrical issues are, but that's pretty vague. There is no SNOMED code for obstetrical issues, I guarantee you that. Our guidelines have contradictions. We say this in one bulletin, 3 years later we kind of look at it from a different perspective and we say that. And the two don't match up. And, as I said before, this is what we've been doing for 60 years and our outcomes are getting worse and worse. So we've got to do something different. So, decision support in the EHR world. When my residents need help, they have Epic open or Cerner open in one window, and they open another window and either go to UpToDate or the ACOG practice bulletins and read the narrative and then try and figure out what they should do for the patient before them. Not the right plan, right? It's constrained by a lot of problems that I've enumerated here, and we don't need to go into them, I think, but where can we get to a future state? How are we going to tie this all together with application programming interfaces? We've addressed the interoperable data models, but how can we address these care pathways for digital platforms? And, obviously we're all here to talk about BPM Plus. Knowing what belongs where's the pathway live? Is it in the EHR? Is it an app over top? Where does the data live? Kind of getting that all sorted out, I think, is the challenge that lies before us. And this is where we'd like to get, right? We're still going to have EHRs. Those systems, the interfaces, the connections with the lab and the radiology and the billing systems, still going to have to exist. But can we have an app for the care pathway? Can it pull data from a library of pathways? Can it communicate not only with the EHR for a source of data, but with a bunch of other data silos that are out there? That would be an ideal future state. I don't think we're quite ready for that, but we've got to take a step. Take a couple steps here. So, you guys all know APIs. We don't really need the Expedia slide, I think. We understand data models. You guys all know FHIR, right? Don't need this one then either. And here's, of course, our BPMN model with the swim lanes for the different roles and the different tasks, and you're all familiar with the decision models as well. I have to say, I'm fairly new to this BPMN DMN modeling, but I got to tell you, I haven't come up with anything. Now, and given that obstetrics is, the dumbest people in the med school class went into obstetrics, right? It's not super complicated, but except for Kate. Given that, it's not super complicated. I haven't come up with anything that we couldn't model in this expression language. So, what are our goals within the IT group at ACOG? We are creating care pathways for digital platforms. Platform agnostic. I don't care if they're EHRs, mobile apps, web-based apps, direct to patient-facing, whatever the vendor community now or in the future wants to come up with. We want to do our part to supply our knowledge as an artifact that they can consume. It's not going to be a narrative, right? We want to coordinate this effort with other professional societies, which I think is kind of why we're all here today. We've presented this work to the American College of Surgeons. They're very supportive. ACC sends their regrets. They're not here, so I can make fun of them. But they're involved. I've been talking to the pediatricians. I know emergency room folks are in the room today. But I think we've got to build that critical mass of professional societies that are going to agree on this. And I think that's really, where we'd like to go from an organizational standpoint from this meeting. Also, of course, want to call out affiliations with some of the other organizations out there, the Health Services Platform Consortium, HSPC, which, let's see, I think there are at least 2 board members in the room right now. MITRE, of course, we have represented here today. OMG, you guys. I handed Don Rucker a flyer for this, but I don't see him here. Is there anybody from ONC here? Great. Glad to have you. Delighted. Terrific. But, how to coordinate this with the various other organizations out there. I'm also going to point out some internal goals we have within ACOG. We're finding that, as I said, the practice guidelines, the narratives as written, have contradictions, have vagueness, and so internally, we are feeding back to practice, during the generation of these narratives, to say, hey, you can't really say obstetrical issues. Put a box, list them. You don't have to put the SNOMED codes in because no clinician cares about those, but at least let's use terms that are, that have some, specificity about them. Let's get the logic right. We have, Robert and I spent quite some time modeling a model we have for treatment of suspected influenza in pregnancy. And, even a novice modeler such as myself was quick to recognize our guideline makes no damn sense at all. So we were working with that internally to be at the table when these things are generated and say, hey, from a logical standpoint, you can't say this here and then say that there. That's not going to work. The care pathways have to contain a certain number of things. They have to contain the data elements, the rules, the decision models. We're going to incorporate performance measures, ECQMs, maybe CQL scripts that have to be the components of these models. And so how do we do this? Well, we are using our use case as antenatal care. We started by taking our narratives and we scraped, I think our numbers around 1,400 specific recommendations out of these narratives. I stuck them in a relational database and we mapped them to around 200 separate, and I'm going to use this word semantically incorrectly because for the clinicians in the room, we talk about a problem list. Well, that's like what big medical issues does this patient have? And we're using it in a slightly different way, more like, what threads are we working on for this patient, right? Every obstetrical patient needs a screening for alcohol use and for tobacco and for depression and anemia and et cetera, et cetera. Those aren't problems on the problem list. Those are just things we're working on. So we came up with that list, about 200. We did all the cross-mapping. And now we have that relational database. I can take a problem, literally drag and drop all the recommendations into a BPMN modeler. Thank you, Denise. And make the model. And when I've associated every one of those recommendations with some point in the model, then I'm done. And then I have to fill in all the gaps, of course. We then send that model out for subject matter expert review. We have a small phalanx of, for antenatal care of maternal fetal medicine docs, and also some boots on the ground docs that practice every day and say, hey, does this pass the smell test? Is this what you do in real life? And we get their feedback. And then we bring it back to an ACOG working group that we've established. And the job of that working group is to decide whether that model, that artifact, can go out the door with the ACOG seal on it as an ACOG-endorsed product, or does it have to go up through further review, like our narratives get reviewed? And just to give an example of that, in obstetrics we have a condition where the placenta is low and covers the cervix. And you know, it happens. And when that happens, the first thing you tell the patient is, oh my goodness, Mrs. Jones, don't put anything in your vagina. No tampons, no douching, no intercourse. Don't put anything in your vagina. That particular bit of advice, while universally accepted as standard of care, is nowhere to be found in the ACOG recommendations. So you know what? We're just going to put it in there and send it out the door because that's what everybody does. On the other hand, and we'll go into this in the workshop this afternoon, we have a model for hypothyroidism in pregnancy. And if you have hypothyroidism, I'm going to give you a drug. I'm going to give you some Synthroid. And Synthroid in some people can cause intermittent atrial fibrillation. And I am not a cardiologist, okay? So if my patient's getting intermittent AFib, I'm going to have to consult cardiology. That makes sense to everybody here, but I got to tell you, that is way outside of ACOG guidance at this point. So if we're going to include things like that in the model, the working group might say, you know what? You're outside of the box here, Steve. It makes sense, but we're going to want to review this further. But the point is, we want these artifacts to have just the same kind of thorough, thoughtful review that our narratives do, so that we can stand behind them as ACOG products when we get them out there on the street. What have we done so far? We've got about 30 models already created for antenatal care. We're working on the big new OB workup, and we're working on a postpartum model. Let me also introduce my grad student, Letha Suter, who has admirably modeled the CDC guidelines for medical eligibility for contraception, which we're getting a lot of affirmation from the CDC for taking this on. And it's a big, ugly model, let me tell you. Beautiful model, beautiful model. But that's another thing we're working on. We are starting to work on the routine gynae visit, well woman, and some subsets of that, including pain and bleeding, menopause, genetics. So we're ramping this baby up. We're modeling like crazy. That's kind of our progress to date. we kind of talked about this, how we're integrating our informatics input into the guideline creation. So why do this, right? Is it just because Kate and I don't have anything better to do and we have a shiny new toy that's really fun to use? No. We want to improve the process of care. We are desperate to find a way to move the needle on these outcomes that are embarrassing. We want to see what we can do to reduce provider burden. And at this point, let me note that we are delivering these BPMN artifacts to a startup that we are working with. They are incorporating them into their build. And this morning, while we sit here in this conference room, I have 1,000 docs in America that are using that app that is powered by these BPMN models. And I'm going to tell you, they love it. We're reducing 20 clicks to 1 click. We are really, the emails we get from these guys, I used to be able to see 25 patients a day. Now I can see 40 patients a day and I go home at 5 o'clock. We're getting essentially 90% of charts closed at the time of the encounter. None of this pajama time, stay afterwards for 3 hours to finish your charting, right? So that, we have theoretical reasons, but I got a pragmatic reason. I got a startup who's accepting these things, and we're getting it on the street, and it works. Let me conclude by saying another central motivation of ours to do this work. We make recommendations for 4 million pregnancies in America every year, based on studies that had 70 women in them. Are we insane? We need the data. We've got to close the loop on the learning healthcare system. We've got to have access to the data. What goes on at the point of care? What are the processes? How do people follow these processes? What are the outcomes they end up with? We've got to bring that back into our recommendation generation process. Okay? It's just insane to say, oh, well, we're going to base this global recommendation on this one study that was done in one institution. We've got to get a better system going for that. So we need the data. I don't want to come off sounding like Cambridge Analytica here, but we need to get the data back. So that's our big goal. My ACOG colleagues don't like it when I say this, and Mark, you didn't hear this, but we'll give the protocols away. We just want the data. Okay? Actually, not true. Mark, I'm going to charge you. Okay? Just a little, just a small amount. Chump change. Okay? So, the RSADA we talked about. In my hands, this works. Evaluation, treatment can be standardized. Diagnosis is still hard, right? People have been trying to do artificial intelligence to do medical diagnosis for a long time, and that's still hard. But a standardized evaluation, a standardized treatment plan, that can be done. Other professional societies taking notice. If we can all, get a critical mass going here today, I think we have a chance to transform medicine. So those are my remarks. I'd be happy to take a question or two.